Okay, well, thank you so much. My name is Terren Trott. I'm a graduate of the University of Kentucky Emergency Medicine residency. I followed that with a ultrasound fellowship, followed by a critical care fellowship at Cooper University, and in internal medicine. So I work now in the MICU as well as the emergency department. And so, the title of today's talk is Thrombolytics and Pulmonary Embolism. And I'll really be focusing on how we get to that point. With my training in mind, I'll give you my perspective on some of the crucial decision-making points and diagnosis and management of these critically ill patients. And that's because I believe a whole team on board each step of the way leads to better teamwork and better outcomes. So when we all kind of have a conceptualization of what's going on, I think we can all work a lot better to get the patient managed. So I have no disclosures, and some of our objectives are to cover the epidemiology, pathophysiology, review some of the bedside tools for diagnosis, and examine how we manage these patients. And again, to kind of reiterate the outline of this whole talk, I'll briefly discuss the risk factors. I think the nomenclature of how we talk about pulmonary embolism is important, so I'll belabor that for a second. And then I'll be talking a lot about the empiric diagnosis of pulmonary embolism in cardiac arrest, and that's going to be challenging and nuanced. So I'll cover that in a little bit more detail. And then I'll talk about some of the management aspects of non-cardiac arrest pulmonary embolism, massive PE patients, a little bit on TPA, and I'll mention some of the salvage therapy. But I think we're going to be pretty crushed for time, so I'm going to kind of keep moving. Let's start with this quick poll. Question number one. And I'm launching it now. The diagnosis of pulmonary embolism, let me get this out of the way, sorry. In the emergency department is challenging due to the lack of clinical and diagnostic criteria and imperfect investigations. Presenting symptoms are common and nonspecific, always include chest pain and shortness of breath, low false positive rate with D-dimer or all of the above. So let's see what you all think with the answer. Okay. Symptoms are common and commonly non-specific. And of course, that adds to the challenge of making this diagnosis. And that is the correct answer. So moving on to some of the risk factors for pulmonary embolism, I think we're all pretty familiar with these. These things like pregnancy, malignancy, and these show up a lot into our clinical decision-making tools. So I think we know them pretty well. But I mentioned them here because they do add to our pretest probability, which is important in the diagnosis and management of PE. And then when we discuss how we define pulmonary embolism, there's really two different ways we can do that. We can talk about the anatomic distribution, which is something like segmental, subsegmental, or saddle embolus, which does not necessarily tie into the physiologic definition. And the physiologic definition, I think, largely defines how we manage these patients and can ignore some of the anatomic distributions. That being said, is a saddle PE more likely to have higher physiologic consequences? Yes, but not always the case. Chronicity can kind of play a role there. So again, we'll be focusing on the physiologic definitions. So how do we break down the physiologic definitions of PE? We'll talk about largely massive PE versus submassive PE. So our definition of massive PE is going to be one that causes cardiac arrest, shock with sustained pressures, and importantly, not always mentioned, RV strain. And I'm not sure why this doesn't get mentioned. Maybe it's assumed, but it's a very important part of our massive PE. And sometimes shock is defined as a systolic blood pressure less than 90 or a drop in 40 systolic blood pressure. But I think it should also include all the other symptomatology of shock, such as encephalopathy and poor perfusion. And we also know that massive PEs carry a very high mortality rate, and up to 95% in cardiac arrest and maybe 20 to 35% in those just with shock. So it's a sick population. Now, submassive PE, which I will not be talking about, is your normal tensive patient that still has evidence of RV strain. So how do we diagnose massive PE? We'll start with that. Now, I love when we have a beautiful CT with an awesome saddle embolus. Everyone takes a picture and sends it to their friends, HIPAA compliant, of course, but we don't always have this luxury. And we all know that critically ill patient who's hypoxic, hypotensive, looks terrible, that we're not going to send to the CT. So what we have to do is make an empiric diagnosis. And so let's start with a very challenging population, and that's empiric diagnosis of massive PE in cardiac arrest. Now, there's two things that we have to always kind of weigh in, and that's our pre-test probability and risk factors. So yes, if you were able to get the spouse that said, oh, my loved one has cancer, they've been having shortness of breath for 3 days and have pleuritic chest pain, and then they collapse. That helps a lot. Of course, we don't always have that information. Other things like biomarkers and ECGs, while they have their role in predictive value of submassive PE and massive PE, in cardiac arrest, obviously they are not useful. So the next couple of slides, what I do believe is useful is bedside ultrasound. Now, if you work with me in the emergency department, you know that I try to get a lot of my PharmDs to work with me, grab that probe and put their ultrasound on the chest. Now, that doesn't always happen, and I'm looking at a couple of you guys right now, but I think when we all have an idea of what the right heart is doing and what we're seeing on bedside ultrasound, we're all on the same page and can work to get that patient better. I also love bedside ultrasound and echocardiography specifically because you learn so much about the pathophysiology of the disease state you're treating. So we're going to talk a little bit about right heart ultrasound. And right heart ultrasound, when we consider what the right heart is, it's largely this thin-walled conduit, weak, low pressure conduit for blood to return from the venous system into the lungs and into the arterial circulation. It does not adapt well. And so over the next couple of slides, I'll show you how this maladaptation takes place. So there's two ways that we see it occur. We see volume changes, and we also see pressure changes. As we see increased afterload on the RV dilates. And this is one of the things we look for on ultrasound. As we dilate, we lose systolic function. We actually see chamber size increase, and this can increase very rapidly. In a live patient, it's going to increase within 15 minutes. So the standard ratio that we look for, to be certain, I personally shoot for when the RV is bigger than the LV, we have a problem. And that's pretty clear cut for most of our massive PE patients. Now, the other thing we see is elevated pressure. That acute afterload increase in massive PE leads to things like tricuspid regurgitation, which we can use to measure our RV systolic pressure. And then the other thing it does is leads to intraventricular bowing or intraventricular dependence. And I love this concept because it also demonstrates how the RV can lead to LV failure. As the pressures in the RV increase, eventually those pressures overcome LV diastolic pressures. And that's when we see that septal bowing. The RV is actually impeding the filling of the left ventricle. And it's pretty impressive to see on ultrasound. And it also demonstrates how we can get LV failure from RV failure. So we use these two things and we see the stress on the heart and we weigh that into how we make the empiric diagnosis during cardiac arrest. So let's kind of put a couple of these together when we have that undifferentiated cardiac arrest patient and we're trying to decide what to do. So here's an amazing ultrasound. What we have here is the RV on the left side, of course, to make it confusing. It is dilated. It is nearly akinetic. We have a McConnell sign, which is a nuanced sign we sometimes see in PE. And what we see, what makes this so interesting, is we actually have a clot in transit. This roly-poly worm thing here, this is literally a clot in the RV or in the RA, in the RV, ready to go out and just make things like a million times worse. To me, this is a done deal. I know what the problem is. I'm giving this patient TPA. Just to kind of reiterate this, we see another echo where we see a clot in transit. That's going to be the most sure you're going to be that this patient is dying of a massive PE. And of course, we see all the other signs of RV strain or failure. And again, this patient is getting TPA. Now, that's pretty high on my level of confidence. We don't always have that degree of confidence, so we kind of have to work with what levels down from a degree of confidence, or where are we in that spectrum. And so sometimes what we see is RV strain. Here's an echo of a heart. It's beating. We have an akinetic free wall. We have what's known as a McConnell sign. I see poor systolic contraction. I see dilation. This is RV strain, absolutely. Now, on the right-hand side of the screen, which I always include in part of my cardiac arrest assessment, is I see a non-compressible femoral vein. And so what that means is that we have a DVT. Now, when I combine RV strain plus DVT, I know I have a state of thrombosis. I'm giving that patient TPA in cardiac arrest. Now, from here, it gets a little bit more dicey. What if you have just a DVT in cardiac arrest, but your RV, for whatever reason, looks okay? Are you going to give that patient TPA? I think there might be some practice variation here, but I'm going to say probably not. I think it's very hard to die from a PE if your RV is not absolutely destroyed. I don't know how that actually would occur. So I'm going to say probably not in an isolated DVT. Now, where it gets a little bit tricky in our algorithm here, what if we have a cardiac arrest patient who we do bedside ultrasound in between our pulse checks, etc., and we see RV strain alone? So the question is, should we be giving this patient TPA? And I think the answer is maybe not, which is clearly not that definitive. But recent publication, we had 24 pigs induced into cardiac arrest, either via hypoxia or pulmonary embolism. And here's the problem. Here's where it got dicey, was that these patients or pigs all developed RV strain. And the rate between hypoxia and PE was almost the same. But by minute 8, they almost all had dilated RVs and chambers, all the quantitative ways that they check it. It was, so it adds to our problem of using isolated RV strain to suggest PE. But we'll talk about this a little bit more. Let's kind of wrap up this algorithm of making the empiric diagnosis of PE in cardiac arrest. When you have a clot in transit, that's pretty good data for me. I'm going to say I'm going to give TPA. If I have RV failure and evidence of a DVT, I'm giving TPA. Now, if I have RV failure alone, I have to have a really good pretest probability to convince myself to give TPA. Otherwise, I'm not going to do that. I don't want to just throw TPA out empirically, unless I really have a good reason. Now, when you have a DVT plus no RV strain, I'm not giving TPA. And this kind of begets the point that your pretest probability has a lot to do with empiric treatment of massive pulmonary embolism in cardiac arrest. So we have this spectrum, and obviously there's going to be some practice variation. What I've given you is kind of my approach, and I believe probably the best way to make that diagnosis of massive PE in cardiac arrest, acknowledging that there is going to be some practice variation there. Okay, so let's wrap that section up with another poll. So let's see what you guys think about this one. Which of the following common ultrasound features of RV dysfunction are in PE? RV wall hypokinesis, and that's that McConnell sign that I was discussing. RV dilation when the RV is bigger than the LV, or free-floating right heart thrombus, clot in transit, all of the above. Okay, you guys are crushing this. Absolutely, all of the above. Okay, let's keep going. Now, that's our cardiac arrest patient. That's empiric diagnosis. Let's talk a little bit about management of massive pulmonary embolism patient during non-cardiac arrest, because I do think there are some nuances here that a team approach can be super valuable. So we'll frame this in the classic ABCs. So let's start with, now I love the massive PE patient who's on pressors and has a confirmed diagnosis who can get by on high flow nasal cannula. This offers decreased work of breathing. It can offer pretty high FiO2, and in general, I think is the right answer. It adds a nominal amount of PEEP that in this situation, I'm not that worried about. But unfortunately, we know that not all of our massive PE patients are going to just get by on high flow nasal cannula. So the next step in respiratory failure in massive PE is going to be intubation. And this is where, again, we leave the realm of evidence. You're going to see practice variation. I'm going to provide a little bit of reasoning for one method of intubation. And the reason this is so important is because we have a really rough transition in this sensitive RV patient to positive pressure ventilation. I feel like a good portion of the patients I've seen have cardiovascular collapse after intubation are those with RV failure, and of course PEs in that population. And so what we see is that we have a high mortality. And we know that from evidence from shock indices or any other indices that you would want to measure or predictive value that this patient is going to do bad. We also know that the RV is already in a sensitive position, and going from negative pressure ventilation, spontaneous ventilation to positive pressure ventilation adds that additional strain and burden on the RV, which sometimes it just does not tolerate and unfortunately does not recover from. So when we talk about intubation and subsequently ventilation, which will be the next couple of slides, we have our choice. We can do RSI, which of course I'm a huge fan of RSI. I've practiced a ton of RSI. And alternatively, we have awake intubations. Now, there is absolutely no randomized controlled trial comparing RSI versus awake intubations in RV failure. But what I'm going to propose to you, and I'm not saying it's necessarily always right, but why an awake intubation may be right for a selected massive PE patient. So let's talk about what is an awake intubation, and that's an intubation where you maintain spontaneous breathing with cough and gag reflex, which will be a problem, and ideally you maintain hemodynamic neutrality, which of course is super important in this patient. By doing awake intubation, you can avoid paralytics, you can avoid full dose sedatives, and maybe you still retain that catecholaminergic surge of that patient fighting for their life. And I think that has a valuable component to the survival of these patients. So as I said, the cough, how we do an awake intubation with this slide, and without getting into the nuts and bolts, we need to topicalize the pharynx, the hypopharynx, so that we have an anesthesia to the blade entering, the tube entering. We're going to do this with 4% lidocaine, and we're going to aerosolize or nebulize 4% lidocaine as well. And ideally, what we're doing is removing that cough and gag reflex so that we can transition the tube into the trachea smooth or without resistance from the patient. Now, in terms of sedation, I'm using low dose ketamine. And my practice, in the patient population that this is going to work, it takes very little ketamine. It's like a sub-dissociative dose. So I'm usually starting between 10 milligrams and 15 milligrams, and I'm giving very small aliquots, which may be somewhere around 0.1 mg per kg of ketamine. And I'm trying to get the patient in a comfortable state. Now, clearly, to do all of this, you have to have a patient that's going to work with you. It cannot be the patient who's satting 65 on pressors and unconscious. That's clearly, we need to get the job done. So low dose ketamine is what I'm choosing for sedation. And at that point, I perform the awake intubation. And this can be done with video laryngoscopy, direct laryngoscopy, fiber optic intubation. It doesn't actually matter. That part does not matter, whatever you think the patient is going to tolerate and what you're good at. And there are some inherent challenges. So when you see someone struggling and they may be trying to time the tube going through the cords of spontaneous breathing. So like I said, this patient, now that we've got the patient intubated smoothly, their blood pressure does not change. They were completely comfortable the entire time. And now we're transitioning them to ventilation. So like I said, it's that positive pressure that can be a challenge for the RV. So what our goal is to ease that transition as smoothly as possible. So the reason we did awake intubation is, one, to maintain their spontaneous breathing. And that way I can actually put the patient directly on pressure support, not mandatory ventilation. Had we paralyzed, it would be mandatory ventilation. Here, I'm adding a little bit of inspiratory support, and that's just so that when the patient initiates a breath, the machine adds a little bit of pressure just to overcome the resistance of the tubing. And here again, key is I'm actually starting at a PEEP of 0. Now, if you walk around any ICU and you look at every ventilator, not a single one is on a PEEP of 0. So I know this is a little blasphemous. Now, I'm not leaving it there, but I'm starting it there. So the patient is breathing. Basically, all I've done is put a tube in their mouth and add a little bit of inspiratory support. The thoracic pressures should not have changed. And then I'm titrating up PEEP slowly and as tolerated, making sure maybe over the next 30 minutes to an hour, I'm getting to a PEEP that's more normal to prevent atelectasis, etc., without demonstrating hemodynamic collapse. And at that time, I'm also titrating up propofol or some other sedative as my ketamine is wearing off. Now, does this work every single time? Absolutely not. Sometimes the patient hates it and we do RSI and we get the job done. But I've also had anecdotally very good success with making a very neutral, smooth intubation. It's something that kind of has to be acknowledged to the entire room and then played a little bit by ear. So it can be a little bit touch and go. But I have had good success with this. Now, to continue on with management, circulation, I'm a big fan of norepinephrine in these patients. Vasopressin for the pulmonary vasculature sparing, I think is super important and would be my second line. And then I'm also considering things like epoprostenol and nitric oxide as pulmonary vasodilators. Now, I don't always know that these work, and especially if you look at ARDS data, does it improve SpO2? Probably. Does it improve outcomes? The patient population that would benefit from these, in my mind, are those with RV failure, and maybe that's where our crossover is with ARDS patients. I think there are some high fidelity ways of adding these medications. You could do RV stroke volume via our ultrasound as well. So these can be definitely considered in refractory cases or salvage cases. So the next big one that comes up a lot is fluids. And truthfully, we don't have good data to guide this. Now, when I was a resident, for whatever reason, my training was patients are preload dependent and they need fluids. But as I've come to learn and respect the RV maybe a little bit more, I can't help but to say my opinion on this has changed. And now I see fluids as maybe adding to the volume of the RV, adding to the pressure of the RV, and possibly worsening that RV failure. And when I think about the RV patients I have in the ICU who are vented from ARDS, I'm often actually pursuing a route of diuresis. So to say shortly, I don't empirically pound these patients with fluids. That's absolutely out of the question for me. And when it comes to fluids versus just going to pressors, I think we have a little bit of data in somewhere around 18 randomized dogs who actually did a lot better with norepinephrine versus fluid boluses. I think all the fluid bolus beagles died, actually. But that's a study from like 1984 in 18 dogs. So we really don't have good data to guide this. Okay, so the title of the lecture was Thrombolysis and Pulmonary Embolism, and I'm 2/3 of the way through and I have not talked about TPA. And that's because TPA in massive PE is a challenging topic, and it's a very nuanced topic, and it's full of low quality data that is quite tedious to get through. So let's go with this poll right here. Actually, I'll take this back. This is a trick question. Use of fibrinolysis in PE is a controversial topic. Which of the true? Most agree that cardiac arrest and hemodynamic instability, less than systolic blood pressure of 90, are indications for thrombolysis. Controversy surrounds thrombolysis for stable patients with RV dysfunction. Benefit must be weighed against the risk of hemorrhage, and thrombolysis has not been shown to improve mortality in submassive PE. And the answer to this trick question, because honestly, all of these are true. And so teasing out the data of pulmonary TPA in cardiac arrest is a challenge. And I actually don't have the strongest feelings about it. I think the decision to give TPA is one of the biggest hurdles, but then we get into some of the discussions about timing and dose. And so when it comes to these two questions, which I think are probably our more practical questions, overall, I'm in agreement with both the European Society of Cardiology and the CHEST guidelines that one, thrombolysis is indicated in our massive PE. And I, in general, defer to their kind of not that evidence-based guidelines. That being said, the data has looked at pushes from 1 minute to 2 minutes to 15 minutes up to 2 hours, which of course makes no sense in like a cardiac arrest patient. And the dose we know has gone all across the board. We could extrapolate catheter-directed thrombolytic doses of 4-8 milligrams from the Optimize study, or the more common 0.6 milligrams per kg up to a dose of 50 to 100 milligrams in like the PIAPET study, which of course was a case series of only 23 patients. So I don't have the strongest opinion on this. If I were to have no other influence whatsoever, I would push it under 2 minutes and I would use a dose of 50 milligrams and I would repeat another dose of 50 milligrams if the first dose wasn't responsive after 10 minutes. And that's a poor simmering of all the data of the poor data that's out there. And of course, we could summarize all the different lectures, different studies, but I think that's a little bit tedious, especially when we don't have good conclusive evidence. So after we have considered TPA, we also have to consider salvage therapy. And this may be something like VA ECMO, surgical thrombectomy, or catheter-directed therapy. And this is largely going to depend on what institution you're at and what the local practices are. And so when it comes down to TPA and these salvage therapies, I think having things like a PERT team are very logical, and having a unified approach to what your options are in cardiac arrest or in massive PE makes a lot of sense. And having a team-based approach to these critically ill patients is the way to go. So with that, I'll wrap up and answer any questions.